Hi everyone, I am Dr. Rashmi. Today's class is about appendix. Appendicitis is the most common cause of acute abdomen. Appendicectomy is the most common surgery performed, and appendix was once thought to be a vestigial organ but maintains the gut microbiota and helps in the immune function of the bowel. And appendicectomy is found to be protective for ulcerative colitis because of modification of bacteria and immune function. So, coming to the anatomy of the appendix, it's a blind muscular tube arising from the cecum with mucosal, submucosal, muscular, and serosal layers like other parts of the bowel. The mucosa consists of columnar epithelium, colonic type of columnar epithelium, neuroendocrine cells, goblet cells which produces mucin. So the base of the appendix is found at the confluence of the three tinea coli of the cecum. This is very important during surgery if you want whenever the appendix is not easily visualized intraoperatively. So we need to follow these tinea coli to identify the base of the appendix. Position of the tip of appendix is variable, retrocecal being the most common position, and the pelvic is 21% and followed by other positions such as pre-ileal, post-ileal, paracecal and subcecal. Blood supply, appendicular, it is supplied by appendicular artery, which is a branch of ileocolic artery, which is in turn a branch of superior mesenteric artery. The lymphatics of appendix are drained by ileocecal lymph nodes. Coming to microscopic anatomy, so the length is microscopic and macroscopic anatomy. The length is around 7.5 to 10 centimeter. The lumen is irregular. So crypts contain Kolchitsky cells, that is the neuroendocrine cells, leading to carcinoid tumors, and appendix is the most common site for carcinoid tumors. Submucosa contains lymphatic aggregations of follicles, and lymphoid hyperplasia is most important for the pathogenesis of acute appendicitis. So we'll go on to acute appendicitis. That is, first step is luminal obstruction. So when the lumen of the appendix is occluded, there will be elevated pressure in the lumen because of the increased mucin production by the goblet cells and the gas produced by the bacteria, which causes distension, in turn causing venous congestion and mucosal ischemia, which in turn causes transmural ischemia and perforation of appendix. So once appendix gets perforated, there will be release of high amount of bacteria, mainly gram-negative and anaerobes. So causes of luminal obstruction are fecalith, that is consisting of fecal material, calcium phosphate, bacterial and epithelial debris. Second is fibrotic strictures because of previous appendicitis, neoplasm and parasite, especially the pinworm, which proliferates inside the lumen of appendix. Risk factors for perforation of appendix: extremes of age, immunosuppression, diabetes, fecalith and previous abdominal surgeries. Symptoms of appendicitis: periumbilical pain, which is shifting to right iliac fossa. Appendix, being a derivative of midgut organ, is supplied by T10, which is corresponds to the dermatome around the periumbilical region. The distension causes visceral pain that is felt at the periumbilical area. Once the distension is increased and the appendix starts irritating the parietal peritoneum in the right iliac fossa, the pain shifts to the right iliac fossa. So it is associated with anorexia, nausea, vomiting and fever, and loose stools and burning micturition. Signs of appendicitis: McBurney's point. So this is a point of maximum tenderness. So the McBurney's point is situated at the line joining umbilicus and anterior superior iliac spine at the junction of medial 2/3 and lateral 1/3. Rosing sign: pain in the right iliac fossa when lower quadrant is palpated. Psoas sign is extension of right hip causing pain, mostly seen in the retrocecal position. So the patient will have the flexion deformity of the hip joint. So obturator sign, whenever you internally rotate the right hip, it causes pain because of the spasm of obturator internus. This is mainly seen in pelvic position of appendix, irritating the obturator internus. Pelvic position can lead to early diarrhea and increase in frequency of micturition, that is because of irritating the rectum and the urinary bladder. So coming to investigations, laboratory investigations, mainly there will be leukocytosis and increase in neutrophils and band forms, that is known as shift to left. So we need to calculate Alvarado score, Mandrel score, so which is a very good predictor of appendicitis. So coming to the symptoms, migratory right iliac fossa pain, anorexia, nausea and vomiting all score 1 each. And in coming to the signs, right iliac fossa tenderness scores 2, rebound tenderness 1, and if the patient has fever, scores 1. Laboratory investigations, leukocytosis scores 2, and the shift to left, that is increase in neutrophils and band form, scores 1, and total making a total score of 10. So whenever it is more than or equal to 7, it's a strong predictor of appendicitis. Radiological investigation, USG abdomen is most commonly used, showing enlarged, immobile, non-compressible, blind tube arising from the cecum. So secondary signs are free fluid, hyperechoic mesenteric and enlarged mesenteric lymph nodes. Plain radiographs shows calcified fecolids, and it is also used to rule out pneumoperitoneum for other abdominal emergencies. CT scan abdomen, so using only IV contrast, showing more than 7 mm appendix with fat stranding. MRI abdomen is reserved for mainly pregnant females. Differential diagnosis, first in children, acute gastroenteritis, mesenteric adenitis and Meckel's diverticulitis. In adult, ureteric colic, perforated peptic ulcer, torsion of testis. Third is adult female, Mettel's chemers, that is the ovulatory pain seen in the mid-cycle when there is release of ovum from the ovaries, and pelvic inflammatory diseases, ectopic pregnancy, torsion of ovarian cyst, endometriosis. And 4 is elderly. In elderly, diverticulitis, colonic carcinoma and superior mesenteric thrombosis. And the treatment part I'll talk about in the next part. Thank you.